confident that you would all benefit from his insight and experiences. Also, equally bright mind and former resident as well, former classmate of Dr. Akimbo's Howard University residencies, Dr. Didi Omiyi, who's joining us. He's also one of the founders of Operation Stand Walk Run. Dr. Omiyi has joined myself to perform surgeries in Nigeria, and is a busy joint replacement surgeon here in the US. So he'll bring his perspective of experiences on both sides of the pond to today's discussion. Last but not least, myself, Aham Onyike, I'm orthopedic surgeon in Washington, D.C., Maryland, and Virginia, also a founder of Operation Stand Walk Run, currently maintain an active practice here in the United States as well as in Nigeria. And I find myself traveling multiple times a year between the two countries to do surgeries. So I have personal interest in today's discussion and look forward to sharing it with everybody on this forum and others beyond. This session is being recorded, and we will be able to share it beyond today on YouTube, on our YouTube channel. Without further ado, I'll hand over to Dr. Akimbo to introduce the topic, the speaker, and spearhead the discussion from here. Thank you.
Thank you, Dr. Onyike. Before I introduce our speaker, I want you guys to know that as questions come up, you can type them in the chat box, and we'll address them at the end of the talk as well as during the discussion section. So I have known Dr. Shah for about a decade now. When I first asked him to give this lecture, he couldn't have been more excited. As he nears the legacy phase of his career, he told me he was looking into more and more ways to give back. He'd gone on a medical mission to Nigeria and couldn't wait to go back. When I asked him for a bio or profile to introduce him, he said to introduce him as just a guy that likes to operate. But I think we have to do a little bit more than that. Dr. Shah is a fellowship-trained joint surgeon and the director of outpatient arthroplasty at Brigham and Women's Hospital. He's also faculty at Harvard Medical School. His clinical practice is focused on rapid recovery with a focus on getting patients home on the day of surgery. So he's especially suited to give this lecture. He went to medical school at Tufts University and did his residency at Tufts Medical Center. His fellowship in adult reconstruction was at the historic New England Baptist Hospital, and he was an attending there for a few years before moving over to Brigham and Women's Hospital, also in Boston. Dr. Shah is a consummate teacher and travels around the country teaching other surgeons the latest techniques in arthroplasty. He serves on several national orthopedic committees that are too numerous to actually list here. He's the winner of many accolades, but the one he's most proud of is Teacher of the Year, which he's won 3 times now. Unfortunately, Dr. Shah can't be here in person as an emergency situation at his hospital caused him to take call, but he was gracious enough to record this lecture for us today. Fortunately for us, it is a great lecture, and without any further ado, Dr. Shah.
Good morning. My name is Vivek Shah, and I'm very grateful for the opportunity to speak to you all about outpatient arthroplasty. I jokingly say, is it all in your head? And I think you guys will understand why I made that the title of my talk. I want to thank Dr. Akimbo for inviting me. I've known him for many years as he was one of the first fellows that I had in my career, and we've kept in touch, watched each other's careers change. And when he was a fellow, we were certainly not doing this. So I currently work at Brigham and Women's Hospital in Boston, and I had the great fortune to have come to Nigeria 2 years ago as part of the GINCO mission, and had an opportunity to do some large surgeries there. And I've seen that outpatient, or at least discharging patients on the same day, is very doable for you guys, because patients there don't have access to many of the things that we have in the US, and they were able to get up and walk after big revisions. So hopefully I'll convince you that this is something that's possible. So here are my disclosures, none of which are really relevant to what we're going to be talking about. I serve on a couple of committees in AUKUS and AOS, but other than that, nothing of relevance. So, traditionally, the typical hospital course historically involved general anesthetic with a femoral nerve block. So patients who had total knee replacements really couldn't get up and walk because they would fall because they had no quad function. We were giving patients large doses of narcotics. Patients were having a lot of post-op nausea and vomiting, and for total knees, again, we were using CPM machines. Total hip replacements had limited weight bearing because we weren't sure what the implants could tolerate. And we had a lot of precautions on them because we were so afraid of dislocation. So even as recently as 7 to 10 years ago, no hip replacement or knee replacement patients were actually walking or ambulating on postoperative day one. Typically, they'd be in the hospital for 2 or 3 days, and then 1/3 of patients were going to rehab. So the idea of trying to get patients home in a shorter time course was very daunting because the standard total joint arthroplasty course in the first 48 hours was very variable. Patients had a lot of pain. They had medical complications, which we'll talk about, that often occur in the first 48 hours, along with all the complications because of all the medications we were using to control their pain, including nausea, constipation, and then just swelling of the operative extremity. So, when do these medical complications occur, which is one of the big reasons why I think we used to keep patients in the hospital. This is a NISQIP database study published in 2019, so pretty recent, looking at 4 major medical complications: MI, CVA, PE, and death. And we looked at the timing of inpatient greater than 24 hours versus outpatient surgeries, less than 24-hour stays for both total hip and total knee replacement patients. And in general, not surprisingly, what was found was that the patients who are at higher risk for these complications were those patients we all know are the older patients, patients who have a higher ASA score, or they were admitted for a fracture diagnosis. Cardiac events occur in the first 24 to 48 hours, and pulmonary embolisms usually a little bit later at post-op day 2 and 3. CVAs were sort of variable, but this is really the crux of whether we can get to the point that we're comfortable enough to discharge patients home on the day of surgery. Is how do we assess and account for these complications? So again, you see here in graph form that those complications really occur in the first 48 hours. This has become a very hot topic of conversation amongst arthroplasty surgeons, especially here in the United States. If you look here over the last 1 year in the Journal of Arthroplasty, there have been over 229 publications just on the topic of outpatient arthroplasty. So in the US, the definition of what determines outpatient arthroplasty is sort of variable. It can mean discharge home on the day of surgery. The definition can also include discharge home in less than 24 hours, but can include an overnight stay as long as they leave in less than 24 hours. And this can often be very confusing to patients. And where the surgeries are done also can be variable, either in surgery centers, which are often physician-owned, or from the hospital setting. And all of this really matters from a billing standpoint in the United States. Much of this may not apply to you all, but this is really something that is of importance here and something that really drives where we're operating and who we're operating on as far as discharge home on the day of surgery. So in the United States, why are we really even involved? Well, like everything in the world, and especially in the United States, we're interested because surgeons oftentimes own their surgery centers. So to bring cases to their surgery centers means a higher profit margin for them. On the positive side, these surgeons who do own ASCs can control the OR environment, which has been well known to lead to fewer complications and better patient outcomes. Again, decreasing the complications, getting patients up and walking sooner. Having patients in bed for 3 days will obviously lead to higher rates of DVTs and PEs, and I think that's why we've seen such a drastic drop in this particular complication as we've mobilized patients sooner. Patient-reported outcomes and satisfaction have certainly been shown to be much higher with day of surgery discharge. And then obviously with healthcare being the largest portion of the GDP in the United States, we're trying to help reduce healthcare expenditures, both from a patient standpoint as well as from an insurance and payer standpoint. And lastly, and I listed it last on purpose, is now we're starting to see patient demand for discharge home on the day of surgery, and studies that are showing that patients are actually more satisfied with this experience than when they have an inpatient hospital stay. So is it safe to do this? Well, there are a number of studies that have been performed on this. There are some centers here in the United States. This is from Rush, which is a well-known center for doing high-volume outpatient surgeries. This was a single surgeon series where they looked at all cases which were performed at a surgery center. And they looked at 243 patients and they matched them to a cohort of patients who were not undergoing same-day surgery based on gender, age, ASA, and BMI. A good smattering of cases from partial knees to total knees to hip replacements and resurfacings. And they looked at 90-day outcomes, and what they found was there was no difference in ER visits, reoperations, or major or minor complications between the two groups. So clearly this showed that discharging patients home on the day of surgery was safe and possible. Another high volume center that's known for same-day discharge is the Rothman Institute, and they also looked at reasons for failure, which is one of the big things that we talk about, is how do we know who is not going to successfully be able to go home? Well, they looked at patients who were scheduled for same-day surgery. All of them were less than 75, overall pretty healthy, nobody with a BMI over 40. And I think these last two are pretty important factors. They were able to ambulate without a walker, so they had pretty good functional status, and they had to be agreeable preoperatively to discharge home on the day of surgery. And I think you'll see that I think this is one of the most important factors in what successfully gets patients home on the day of surgery. When they looked at their exclusion criteria, it was all people that we would typically know are not going to successfully go home, larger patients, people who need chronic pain medicines, and they excluded all revision surgeries and bilateral surgeries. And when they looked at their 106 consecutive total hip replacements who were planned for same-day discharge, 1/4 of them failed, which is actually a pretty high number. And this paper was from a couple years ago, so I think this was early in their experience. But when you look at the reasons for failure, it was not the things that we typically think about as far as medical complications. It was patient preference. Patients didn't understand what it meant to go home the day of surgery, so they weren't planned. And the thing that we worry about the most, which is pain, was actually the least important factor in why they discharge home. So I think the idea that pain is going to be what limits patients' ability to go home is no longer the case. A sort of an interesting finding in this was that allergies were also evaluated. And if you had greater than 3 allergies, so 3 or greater, there was a 100% failure rate. And if it was 2 or greater, it was 60% failure. So I think it was an interesting finding that allergies were associated with failure. And then we also talk about jokingly with people with red hair oftentimes have a lot of allergies. So another study which sort of evaluated a success of same-day surgery looked at finding out if there were other factors that caused failure of same-day discharge, sort of just reiterating that this was another group that looked at this out of WashU. And they had only 10% of their joints planned for same-day surgery, so a pretty low percentage of the total volume. But they looked at hospital discharge. So this was not an ASC, this was a hospital, all fellowship-trained surgeons, and this was all prior to the COVID pandemic. And I think we'll talk a little bit about how the COVID pandemic has changed what we're doing. And what they found was that hypotension and delayed spinals accounted for 16% of their failures. Interestingly, again, they found that greater than 2 self-reported allergies and preoperative narcotic use were both statistically significantly associated with failure of discharge home on the day of surgery. So how do we assess whether or not we can send someone home? Well, there are a lot of protocols out there that I'm sure are available to you all. If you contact some of our colleagues here, I'm happy to share our evaluation form with you. But this was one that was published that is pretty well known. It was called the Outpatient Arthroplasty Risk Assessment Score. And it looked at all these factors and basically put patients into 2 categories, either low risk, which was a score of 0 to 59, or high risk, which was a score of greater than 60. And when they looked at their consecutive hip and knee replacements, again, only 1/4 of whom were planned for same-day discharge, what they found was that an OSWR score of less than 59 was 80% predictive of discharge home on post-op day 0 or 1. And if your score, based on all those medical parameters that I listed, was greater than 60, then your likelihood of discharge home on post-op day 1 was significantly less, and this was statistical. They then followed this cohort out further up to 2,000 patients, and again, found that this OSWR score was very predictive of the ability to discharge patients home on post-op day 0 or 1. The score was then validated by a number of groups out of Duke, and this was published at the AUKUS meeting in 2016, as well as NYU in 2018. So I think the idea here is just to show that there are validated tools that can tell us whether patients are going to be successfully discharged home or not. And I think the interesting thing is that all of these studies were performed before the COVID pandemic, when we were not really pushing the envelope of who can and cannot go home. So then, Becker's published this in 2017, and it was a chart that was predicting when 50% of the volume of total joint replacements done in the United States would be able to go home on post-op day 0. And they were predicting that by 2026, about 50% of the over 1.5 million joints we do in the United States would go home on the day of surgery. Well, in 2020, this little virus showed up, and I think this changed this chart significantly, where people who had not considered doing outpatient arthroplasty now could not operate unless you were sending patients home on the day of surgery. So everyone started to transition to figure out how we could get people home sooner. So I would say that there's been minimal change in surgical technique or instruments or implantation over the course of the last 5 years as we've transitioned people home. But I think we have changed our pain control, more regional anesthesia, and increased rapid recovery protocols with use of PT. And these are things that will all be applicable in your practice environment, as I've had, like I said, the great opportunity to come on a mission to Nigeria approximately 2 years ago, and we were doing revisions where patients with nothing but Tylenol were walking on the day of surgery. So I think these last 3 will be things that you guys can hopefully apply in the missions as you start to create this program. So we looked at our protocol here when I came to the Brigham and Women's Hospital 5 years ago, and I think a team approach is pretty critical to being able to get people home. And we published this in JBJS Review, so it's out there for your review, and everything that is in these slides will be available as far as our cocktail and what we put in our spinals. So I think the first encounter when you meet patients is pretty important. I talk to patients immediately about the ability to walk several hours after surgery and possibly go home. I say that to every single patient I meet. And there may be some patients who may not be good candidates, and we can, retract that and tell them they may stay a night or 2. But I think, setting the expectations early really makes a big difference. We explain our protocol, and I've had patients who had knee replacements, 20 years ago that spent 3 days in the hospital and went to rehab for 2 weeks. And when I tell them they can go home the day of surgery, and they're 10 or 15 years older, they hesitate a little bit, but I tell them that the history doesn't matter and that we're better now than we were 15 years ago. And those patients have all gone home and said that their experience was fantastic. So again, the most important assessment is the first visit. So I joke that this was me trying to convince a patient to go home on the day of surgery when I first got here 5 years ago. And this is 2 years later after a global pandemic. Patients were begging to be able to go home because they were either afraid of being in the hospital due to COVID, or we couldn't do their surgeries unless they agreed to go home. So I think the landscape has changed significantly, which helps us to be able to get patients home on the day of surgery. So again, education is paramount to everything. Patients get a phone call the week before. We confirm the date of surgery. We talk to their coach. We screen to make sure that they have an appropriate home environment for discharge home. This is oftentimes done by physical therapy and occupational therapy, as well as a case manager. And all patients are required to attend a total joint replacement class, which is now offered virtually, so they can get, again, abundant information and education with regards to expectations, which I think helps people be more comfortable going home. I call all patients the night before surgery. This is something that was taught to me by Dick Scott, and has served me well even prior to same-day surgery. And how you do your cases matters. So I always schedule my same-day surgery cases for my first, second, and third cases of the day. And anybody who I know is not going to go home will be scheduled later in the day. This gives more time to address issues like hypotension with our hydration protocol, nausea and vomiting, delayed spinals. All of these things can then be addressed because you have more time to do them. I think tranexamic acid has also helped I know that this is available in a PO form. So from a cost standpoint, this is something that can be brought on medical missions. It would have to be taken 2 hours prior to the scheduled surgery in order to be effective. And then all of these medications, including nonsteroidal anti-inflammatories, steroids and antibiotics, are given in the pre-op holding area, which help with postoperative pain control. From an anesthetic standpoint, it's been well shown that spinals decrease the use of narcotics, nausea, vomiting, and decrease hemodynamic shifts, which are all reasons for failure of same-day discharge. The spinals must be short-acting, so this is our formulation. Originally, our anesthesiologists were not on board with doing shorter-acting spinals for hips, but now I use the same cocktail for both my hips and knees, which is 4 cc's of 1.5% mepivacaine. And that will usually get you a solid 2 hours and even a little bit more. So I have yet to have a spinal wear off during a surgery. So I think that's also key. And then the general anesthetics are certainly possible. It alleviates the issues of prolonged spinals, but I think the issues of nausea and vomiting are more prevalent with these. So you have to be cautious when using general anesthesia. So mepivacaine really is the go-to spinal. This has been published by a group out of Detroit, showing that there have been fewer straight cath episodes. Again, postoperative urinary retention is a reason for failed discharge home, so we want to reduce that. It was interesting that they showed higher VAS pain scores and narcotic consumption in the PACU, but after the PACU, they were the same. So really, whether you use mepivacaine or bupivacaine is sort of user choice, but mepivacaine spinals were significantly associated with fewer straight caths. So, from a block standpoint, we typically don't do any blocks. There's no femoral nerve block, adductor canal block, IPAC, fascia iliaca block, so you don't need any fancy blocks, but we do use a pericapsular injection of ropivacaine, toradol, and clonidine, and you have to be fastidious about spreading this around if you really want patients to be comfortable so that they can do therapy and get home on the day of surgery. Unlike many private practices that are publishing, here at our institution, we have residents, fellows, medical students. I am not a proponent of saying that any one hip approach or whether you're using a tourniquet or not matters in terms of discharging your patients home on the day of surgery. I think you can do it from any approach and with or without a tourniquet. Again, I think being efficient about your surgery and being good with your pericapsular injection are all as important as anything else. So in the PACU, all patients get a 1 liter bolus. They get IV Zofran so that they don't have any issues with hypotension or nausea and vomiting. And then we institute this multimodal pain protocol, which involves a lot of non-narcotic medications, with the goal to be that tramadol will hopefully be the strongest medication they'll need. Physical therapy, when we started this program, was initiated on the floor. So patients would be transferred from the PACU to the floor. They would then ambulate there and be discharged from the floor. But we found that this prolonged their stay by at least 3 or 4 hours, but it was hard to get therapy on board. But once they saw that patients were able to ambulate and did well, we started having patients seen in the PACU and cleared from the PACU to be discharged home. And this obviously reduced our length of stay significantly by 3 to 4 hours. So we like to have their coach or whoever is going to be staying with them for the first couple of days, usually a spouse or a child, with them in the recovery room to go over all the discharge instructions. For our protocol, you have to navigate stairs. You have to walk safely with crutches or a walker and safely demonstrate that you can do transfers into the bathroom and a car before we let you leave from the hospital. This is one of the biggest anxiety producers for patients is pain control. So what we found in our experience, and I think I've shown this to you from the paper from Rothman, is that pain is really not a reason anymore if you follow the many protocols that are available for failure of discharge. And again, this is not even a reason for readmission. We've had, in our first 100 same-day surgeries, we had 10 failures. Not a single one of them was due to pain that was not manageable. We had delayed spinals, or again, patients did not understand that a day of discharge surgery meant post-op day 0. And we had some hypotension, and this was all before we instituted our hydration protocol. So this is the chart that my PA has created. My patients get all of this in their discharge paperwork. It literally starts at 1 in the morning and goes until midnight, and it gives them an idea of what medications to use and when to use them. And as you can see, we've highlighted that we only really want to be using narcotic medications for severe pain. Otherwise, we really want them to be using Tylenol, gabapentin, and an anti-inflammatory. All patients that get home on the day of surgery get a phone call the following day, which represents another touch since they're not seeing as much time in the hospital. We typically wait till they've been seen by nursing or physical therapy, and that way they've already been seen by someone, and now this is a second touch, and it also prevents readmissions to answer phone calls about dressings that may have some staining on them. And usually the pericapsular injection has worn off by that point. So again, it gives them some reassurance that they're not on an island by themselves, which is one of the biggest issues here in the United States. So a number of symposium at AAHKS have been done on patient experience. Again, these are all at surgeon-controlled, surgeon-owned surgery centers. So they're very regimented and protocolized. And what they looked at was patient factors as far as their concerns about fear and anxiety of pain, risks, medical complications, and the fact that this has always been an inpatient procedure. But when they looked at satisfaction scores, and again, if you look at this, this is now 10 years ago, 98 and 100% satisfaction from patients with really little to no complications and readmissions, and none for issues of pain control. So what I really wanted to focus on, which I think is, I think you've gotten here, is this really all about expectations? We recently all went through New Year, where I think we all make our New Year's resolutions where we're going to be more like these two women on the left. And we find ourselves within 2 weeks of January being more like this gentleman on the right. So, expectations of going home are what guide the ability to go home. So I wanted to look at my patients, particularly partial knee replacement patients. And we started this study to look at medial unis, and the entirety of this study occurred during the COVID pandemic. So you can see the dates here where we enrolled patients. And we wanted to see if the preoperative discussion that we have with patients can influence the patient length of stay. So we looked at all consecutive medial and lateral partial knee replacements, and we prospectively randomized these patients into two groups, either discharge home on day 0 or discharge home on day 1. The rest of the surgery, anesthesia, physical therapy was exactly the same for the groups. And prior to the initiation of this study, every single partial knee replacement patient I did was discharged home on post-op day 0. So we informed all patients that discharge home on the day of surgery, regardless of which group they were randomized for, was possible if they cleared PT. We looked at, we're now at 100 patients, but all except one of the 100 patients now cleared for physical therapy on post-op day 0. So this group was then evenly broken down into approximately 49 now on post-op day 0 and 51 in post-op day 1. Of these patients, only 3 patients crossed over. So 2 patients left on post-op day 0 when they were randomized to post-op day 1, and 1 patient left on post-op day 1, even though they were scheduled to go home the day of surgery. So when we looked at this, we found that, again, we've finally gotten up to our 100 number, which is what we needed. 97% stayed within their designated group, despite the fact that all of them except for 1 were cleared PT on post-op day 0. This included 3 patients who I had done their previous surgery. They had been discharged home on post-op day 0, and they were assigned to post-op day 1, and they kept to their designated group despite having previously gone home the day of surgery and clearing physical therapy on the day of surgery. So what we found was that I think that there are many factors that affect the success of outpatient arthroplasty, and some of these include the discussion that we have with patients. This was the first study, to our knowledge, to demonstrate that our preoperative discussion and setting of expectations can absolutely dictate the length of stay for patients. So, why do we, do outpatient surgeries? Well, many of us are salaried, so there's no motivation. We work with nursing. We don't control the environment. So why do it? We don't own ASCs as academic surgeons. We don't have gain sharing. There's no real power. And it definitely has been proven to increase the workload that we're required to do. So why do we do it? Well, I think one of these things is, the myth is, well, it loses money, so why do we do it? At least in the hospital setting, this is sort of a busy chart, and this is from the Brigham and Women's Hospital. This was published in the Journal of Arthroplasty. what they looked at was the margins on hip replacements and knee replacements, comparing inpatient versus outpatient, inpatient in blue, outpatient in orange. And very clearly, you can see that the margins for our hospitals are much greater for inpatient than they are for outpatient, but they're not losing money. Outpatient joints does not lose money. It just has a thinner margin. So that's the first myth why people say that they, don't do it. The argument that it can't be done in an academic medical center, I think, is also false. I think if you allocate your resources appropriately, it's certainly doable. Again, the same study that had that previous chart showed that here at the Brigham, we have the Brigham main campus, which is a level 1 tertiary care medical center. And then we have a community-based hospital, which functions more like an ASC, which is where I tend to do most of my outpatient surgeries. And what we looked at was, can you improve arthroplasty efficiency and quality metrics by focusing cases at hospitals that are more able to perform these? And what we found is by shifting the BWFH is the Faulkner Hospital, by shifting the case volume to this community-based hospital, we were able to have higher success rates of same-day surgery. And although the profit margins were lower, there was still a profit margin to be had. And that is shown here. So clearly you can see the profit margin is a little bit lower at the Faulkner, but there's still a profit margin overall as far as net margin to be had. So, and then the last thing I'll touch on is, as surgeons, is there really any benefit to us as surgeons if we don't own an ASC, especially if we're working at an academic medical center? As I've saw, there's an increased workload. Well, currency comes in many forms. And for a lot of the young surgeons here, you can certainly get your hospital to buy you capital equipment and have preferred OR times with early starts. It can increase your volume if you're able to do this. And now I know that our fellows in the first 5 cases that they do in practice are doing outpatient hip and knee replacements. And then again, at the end of the day, we're doing this for patients. And there is a lot of evidence out there that patients are more satisfied with their experience when they are doing outpatient arthroplasty. So, and then lastly, of course, is marketing as an option. This was when the Brigham started doing the outpatient arthroplasty. I had the opportunity to sort of head up this program. These are my children. This is a large billboard over Fenway Park here in Boston. And as you can see by my middle child there, who is my youngest, she was not very impressed with Daddy's billboard and Daddy's push to get patients home on the day of surgery. So not everybody is always impressed by outpatient arthroplasty. So in conclusion, what I'd say is this is certainly more work for us as physicians. I think a team-based approach is important. You cannot do this alone. We need our anesthesia colleagues, nursing, physical therapy to all be involved and all be on the same page. Just because patients have not gone home in the past does not mean they can not go home on their second side. And I think one message is very important. This message is the only message that patients need to hear, and we all need to give them the same message that says, if you want to, you're able to go home if you fit the criteria and you check off all the boxes. So, where are we going next? Well, this was published in the Wall Street Journal recently. There are going to be surgery centers from malls. So we're really moving medicine out of hospitals and into just spaces. And the question is, how can we safely do this and successfully make sure that people get home? I think we're getting there little by little. So how does outpatient surgery impact resident and fellow education? These are things to consider. I think this may be something more for us as you try to be more efficient in surgery. There's less time in the operating room. We're not rounding with patients the way we used to with residents and fellows. So the education that happens during rounding is being lost. And what is the future of the academic surgeon? Are we going to be able to survive unless we transition to being more in line with some of the private practice surgeons? And again, this is a significant increased workload for us. Is this really sustainable unless we have people to help us, whether it's physician extenders, PAs, nurse practitioners, case managers? So I think this is an ever-changing environment. So I just wanted to say thank you. I really appreciate you giving me the opportunity. I apologize in advance for not doing this live, but as I told Dr. Akimbo, I'm offering to take call for a colleague of mine who has an unfortunate family situation. So I look forward to hopefully getting emails from many of you in the future and maybe one day joining you in the operating theater. Thank you again. Hope you guys all have a wonderful day.
Okay, so that was the end of Dr. Shah's talk, and that was truly informative and kind of showed us how he was able to build a program at a high-powered academic facility. And the steps he clearly delineated are steps that can be easily executed in any other facility, to include Nigeria. Um, I will start off the discussion by asking the other panelists about their pain regimen with the same-day joint replacement patients. Dr. Nike?
Sure. Specifically, pain regimen similar to what he's described. We're using cocktails intraoperatively. We call it a periarticular injection that includes a combination of medications, mostly non-narcotics. In addition to that, some medications preoperatively. Celebrex is one that we use a lot. Some of the surgeons also use Lyrica. I don't use it personally. IV Tylenol has gained widespread use, and then spinal anesthetic for the surgery itself. So there are some similarities to his cocktail and my own experience.
Dr.
Yeah, I'd agree. We approach things very similar as well at my hospital in terms of a multimodal approach. So Celebrex, steroids, IV Tylenol, a pericapsular injection in surgery, regional anesthesia with spinal and adductor canal blocks. We still will use hydrocodone as a narcotic, but mostly we try to limit that for breakthrough pain, kind of how Dr. Shaw discussed as well. So fairly consistent in our approach in order to get patients mobilized and reduce the side effects of nausea and vomiting from too many narcotics and get them home the same day.
Okay. Dr. Nike, with your extensive experience operating in Nigeria, do you think the meds that you, Dr. Me, and Dr. Shah described, do you think they can be readily available to help with a same-day discharge protocol in Nigeria?
Yeah, they're mostly readily available. I honestly can't speak for all centers, but I'll say for most, at least in the bigger cities, Lagos, Owerri, Abuja, and elsewhere. But I think one of the things we should not neglect that he pointed out is cultural, and that has to do with patient acceptance. So a lot of the patients in Nigeria at this stage would be very skeptical of same-day discharge. That's my opinion. I see some colleagues, Dr. Okanu and Obioha on the call, and so we can involve them and get their opinions. But that's a big part of it, cultural in terms of the medical staff, doctors, nurses, therapists, all believing that it's a safe and appropriate standard of care to discharge patients the same day, and then culturally, I getting the patients to accept it as well.
Yeah, I have to say I agree with the cultural part. I practice in rural America. It's a little different from Boston or DC, where it's not widespread to do same-day discharge for our patients. In some places that do same-day discharge, it's 80-90% of their patients. For us, it's probably the reverse of that. And most people still will rather be in the hospital at least overnight, even though they're not getting anything different. Like, we don't do IV meds. They clear PT the same day. They just don't want to leave the safety of the hospital in case something happens.
Yeah, what's interesting, again, I think that just speaks to the diversity of the country as well, because I'm in a very rural setting as well, but we're kind of the opposite. I send mostly 80-90% of my patients home the same day. We have patients who travel from 2-3 hours, and a lot of them just want to come in, get their surgery, and go back home to their home settings where they're comfortable. So I think there's already a inclination to want to just come to a different state, 3 hours away, get their surgeries, and go home. So that allows us to kind of get patients already primed for same-day surgery, kind of fits with their initial goals. And I would agree completely that pre-op conversation, letting patients know that it's going to be safe, letting patients know that they're not going to be alone, while Dr. Shah describes those touches are really important in the success of our program, at least.
Dr. Okano, Dr. Obia, any thoughts?
And Dr. Okano from Lagos, Nigeria. Most patients is more cultural. Most patients will not usually accept day case surgery. They're just curious that why would they go home so early. But as regards to medications are readily available. Medications that Dr. Shah mentioned are readily available in our country. Thank you.
Dr. Mee, as regards anesthesia type, you'd mentioned you do regional anesthesia, but any experience with general anesthetics for same-day discharge?
Actually, yeah, and let me correct that. I mean, we do regional as well as a general technique for almost all my arthroplasty cases, including patients that we send home. So for a hip replacements, we'll use a combined general and spinal anesthetic. And then for knee cases, we'll do a general and an adductor canal block. In my practice, what I found is that the regional technique beat the spinal, and the adductor canal block both serve different purposes, but for local pain control immediately in the PACU, patients are comfortable from a pain standpoint. The general technique allows for a lot more muscle relaxation in surgery, which I think helps us to be a little bit more efficient in retraction, especially in muscular patients. But they need less narcotics because they have a regional on board. And so we're not seeing the same side effects from general anesthesia in terms of nausea, vomiting, hypotension, because there are less narcotics being used with that general technique. And we push our anesthesiologists to try to use propofol only or Tiva type of approach, and we've had success with that. So it's a little bit different from a lot of different centers, but it works well in our situation.
Dr. Okano, you had mentioned the relative resistance, so to speak, culturally to same-day joint replacement surgery. Do you think it could potentially have a future in Nigeria, or do you think from a cultural perspective, it's relatively out of the question for the next 5 to 10 years or so?
Yes, in future, it will have it may change in future, next 5 years. First is the influence of not just the patients alone, their children also have a big say in the quality of care they receive. So with medication, more awareness, yes, patients may become interested in having their surgeries done as a day case. But for now, I would say that it's not something that eager to accept.
Thank you. We have a question in the chat box. What are some strong indications that will require a patient to prolong hospital stay?
Strong indications. So I think a lot of that will be made in the initial preoperative assessment. And so people that we anticipate will have a long hospital stay would not qualify even at the point of scheduling. So specifically, that includes BMI, weight of the patient. That's one that Dr. Shah mentioned. BMI above 40 is a cutoff criteria for joint replacement surgery period in some hospitals. So that definitely that would apply to anticipation for same-day discharge. It's a medical comorbidities, people with cardiovascular disease, prior history of heart MIs or vascular disease or CHF. Any of those significant comorbidities would preclude people from that, or would anticipate a admission. It's hard to say would anticipate a long hospital stay. A long hospital stay is probably not anticipated ever. It's one that happens because complications arise. It's very interesting too. Again, going back to cultural shifts, I think COVID-19, was a game changer. It really changed the paradigm, because the patients now became the ones more inclined to not be admitted to the hospital, to stay away from the hospital, and that seems to have been a permanent shift. So very often in my own experience, patients are happy when they are eligible for the ambulatory surgery center or same-day discharge. Whereas in the past, patients, would highly question it. So I think that's an important factor that has impacted what we're seeing currently. I'll just also mention that, interestingly, Dr. Shah mentioned allergies as a negative predictor of failure of same-day discharge. I myself had not identified that in my own practice up to this point. However, I think there is something about patients who have multiple allergies that generally results in decreased satisfaction in my own experience. Higher levels of disappointment, higher levels of pain. I sometimes wonder if there's a psychiatric component of that relationship. But I've seen that there, and I wonder what your experiences are, Dr. Mia, Kimbo, and any other surgeons on the table.
Yeah, I'll say like the allergen thing is probably a marker of something else. I think patients that have 6, 7 allergies frequently have a diagnosis of anxiety or depression or other psychiatric factors or diagnosis going on. So I think the allergy is more an indicator of those things that will predict failure for same-day surgery. Other things to add to what you had said about what could prolong a hospital stay will be bilateral surgery, like Dr. Shah had stated, chronic opioid use, as well as revision or conversion to hips. Though more and more people are doing revisions as outpatients as short stay surgical procedures. Certainly, immediate post-op complications will necessitate a prolonged hospital stay also. Dr. Mee, anything else to add?
Yeah, no, I agree completely. I think when it comes to the allergies, I definitely find those patients have had very increased exposure to, the medical field. And when you see patients coming in with, 10, 12 allergies, then, the experiences in healthcare, a lot of contact to get to that point. And I think that there are some components, of, mental health and, anxiety, depression, things like you said, that haven't been quite teased out. And, in those cases, unfortunately, because of lack of resources, you're not able to tease those out, especially to try and treat or address those things prior to surgery. But those ideally, you'd be able to do that to try and optimize those patients better to help to improve the chances that they have a better outcome or better satisfaction out of the procedure. And so something that we probably could do more work on in terms of prepping those patients for surgery. Again, when you're talking about outpatient surgery and same-day discharge, a lot of the work has now moved from post-operative on the floor to pre-operative. So to get our program up on the ground, we had to invest a lot of resources and case managers, physical therapy, pharmacy, anesthesia, to do so many things before the patient comes to the hospital the day of surgery, so they're ready to go. And I see, that conversation as being part of that. The other thing to mention is in the cohort of patients who we end up keeping in the hospital longer, ends up being social reasons. So if we have patients who don't have that coach, as Dr. Shah mentioned, or somebody who can be with them post-operatively, and who may need to go to a rehab facility because they're not able to go home on their own. So I find that that's my biggest population of patients who I do keep in the hospital for a few days so they can qualify to go to a rehab facility for a few weeks before going home alone.
Okay. We have another question in the chat. What are possible preventive measures as regards bleeding post-operatively, especially when tourniquet is used intraoperatively?
I think tranexamic acid has really been a game changer. I think we'll all agree in terms of reducing post-operative blood loss. So in our facility, I'll use for knee replacements, we'll use intraarticular at the end of the case. and hip replacements will use it IV, one dose prior to incision, one dose at closing. And so that's really helped to decrease postoperative blood loss.
What is your intra-articular or topical TXA dosing?
So we use intra-articularly, we'll use 2 grams in the joint, and in the IV, we'll do 1 gram prior to incision and 1 gram at closing. So it's still 2 grams, but just administered at different times.
So is it 2 grams and 50 cc's, intra-articular 2 grams and 100 cc's?
2 grams and 50 cc's.
Okay. Dr. Nyike?
I usually don't use it intra-articularly, not frequently at least. When I have a higher suspicion of bleeding, then I will. And in that case, I do 2 grams as well. One thing I'll add to that is that to answer the question, fortunately, postoperative bleeding complications has rarely been an issue. Recently, gone less and less to using drains, which was part of the standard before. And for the patients who go home, I never use drains. But when there's a high index of suspicion of potential bleeding, in my hands, revisions have that higher probability. And then also in patients who have significant synovitis, sometimes I find myself doing a synovectomy when there's obvious synovial tissue pathology, and those patients may have a higher likelihood of bleeding. So in those cases, I'll let the tourniquet down prior to cementing, use electrocautery to get any of the obvious bleeders, and then let the tourniquet back off. So that's an additional technique that one can use to prevent postoperative bleeding.
Yeah, I'll add in my 2 cents. We'll say, want to get a good idea of what the hematocrit is pre-op, because if the patient is anemic pre-op, they're going to be anemic post-op. So for me, if it's less than 30, it's not a surgery that we're going to do. We'll have to get things optimized before going ahead. I mean, if the hematocrit is less than 30. If it's between 30 and 36, we typically will go ahead, but we'll take additional measures. Additional measures meaning maybe using an Aquaman for the surgery as opposed to just a regular Bovie. I typically drop the tourniquet every time to see if there are any bleeders and achieve hemostasis that way. I've had 2 cases actually this week, and one of them, all the implants were in to include like the poly. We're about to start closing, drop the tourniquet, and there was arterial bleeding from the back of the knee. I would take out the poly and get hemostasis and then gel foam. And I added another 20 minutes to the case. We'll say another thing will be DVT prophylaxis. In people that have a low hematocrit, it might make sense to lean more towards aspirin for DVT prophylaxis, if medically appropriate, as opposed to things like Eliquis or Lovenox. TXA for sure, and that's tranexamic acid for sure, to help with decreasing the risk of bleeding. And I feel like historically the numbers were about 50%, at least from the Baptist. And we'll say in my hands now, in people that don't have anemia, it's probably 0%. And then you should have hemostatic agents like gel foam available at your hospital. You don't need them for every case, but sometimes you can run into trouble like I did, and those agents will definitely help.
Yeah, so I think just to chime in on that a little bit more. So I guess when we talk about bleeding, there are 2 aspects of it. One is significant postoperative anemia, and then the other part is hematoma. Hematoma is probably what I worry about a little bit more, because preoperative screening generally captures people at risk of anemia. And then we can transfuse, which we hardly ever do anymore, but we can transfuse to correct the anemia. But a hematoma, particularly with knees, can compromise a result, both in terms of higher risk of infection and also of postoperative stiffness. it puts them behind the 8 ball, and sometimes they never catch up. So those are the two different bleeding complications that come up that one has to factor into plans and protocols in shifting to outpatient joint surgery.
We have another question from Dr. Stevens. Dr. Stevens is one of very high volume shoulder surgeons in the United States. And his question started with a preamble. We're working towards doing the same, meaning same-day surgeries for shoulder replacements. However, the patient population tends to be older than the average age for hip and knee replacement populations. So the question to you guys is, how do you handle older patients that have few health issues and help at home? Meaning like don't really have a lot of resources at home, sick. And is there an age where you actually admit patients for observation? Dr. Mee?
So in our practice in general, anybody over 75, and I think Dr. Shah also mentioned this in some of the literature he presented, we, definitely have a more extensive conversation that, there may be somebody who we need to admit overnight for monitoring again, just generalized category to kind of screen them a little closer for some of their health issues and also their mobility issues when it comes to, ambulatory function after surgery for hip and knee replacements, of course. So 75 is kind of a cutoff for that. But again, I have patients who are in their late 70s who are motivated to go home. And if they have enough help at home and otherwise doing well, we'll send them home the same day. So I think 75 is kind of the cutoff in our practice. And then in terms of, again, if they don't have help at home, those are, again, the patients that we'll usually keep because they'll usually have to go to a rehab. But we try to catch all those things in our preoperative screening. If they have help at home otherwise and they're doing well and they're motivated, then even patients in that category can go home the same day.
Yeah, we'll say in our setting, it's more of a physiologic age thing than a chronologic age. So we don't have a limit on age per se, but we typically encourage all patients to have help at home. In certain cases, probably most cases, we still send patients without help at home, but we typically will set up a visiting nurse service for them, so they'll have someone that will come in with PT, with a visiting nurse to check on them and give us reports if there are any issues. Another question for you guys. Dr. Shah did not want to wade into the debate of approaches and same-day surgery. But I learned my posterior approach from Dr. Onyike. I've seen Dr. Omiye in the OR, and I know you do a lot more anterior approach hips. I do both, and I have my biases, but Dr. Onyike, what do you think about or defend the posterior approach as regards same-day surgery? And then Dr. Omiye, you do the same for anterior approach hips.
Defend, I'm not sure it's the right premise to.
I said defend because,
I hear you. Yeah, I hear you. Still, I think it's fine. I do almost exclusively posterior approach for elective hips. I do anterior for patients where I suspect dislocation in femoral neck fractures. And that's a different discussion that I'll leave for now. So with the posterior approach, all the milestones that are expected for discharge are easily met. Ambulation in the recovery room or PACU, appropriate levels of pain, duration of the case. There's really nothing that I can think of that will preclude that approach being a reason that the patient will not go home. And in my own personal experience, it's been highly successful.
Dr. Mee?
Yeah, again, this is a very congenial debate because, I don't disagree with anything Dr. Onyike said. I think that with current approaches with, mini posterior approach with less dissection and, using bigger heads and, for the risk of dislocation for posterior approach, which historically was one of the reasons why people advocated anterior. I think that those dislocation rates are very similar now, or close to the same, maybe slightly better with anterior, but within a few percentage points, depending on what you read. And so, and that, keeping patients in the hospital to teach them hip precautions and prevent the risk of dislocation when it comes to hip replacements, I think that's less of an issue nowadays. I do think from someone who switched from posterior approach to anterior approach, in my hands, I think my patients do have a little bit less pain in their medial postoperative period, and ambulating and off their walkers, a week or two earlier. And again, I'm able to assess my component position to a comfort level where I'm less worried about dislocation postoperatively, and so I'm more comfortable. I have been more comfortable sending them home the same day. But I think that a well done hip in anyone's hands, regardless of approach, still is a candidate to go home if all those other social factors are met.
Yeah, I think I agree with both of you. I still actively do both for elective total joint replacements. I think the anterior approach patients might have subjectively improved pain control and tend to lose their assistive device a little quicker than the posterior approach patients. That said, it's not by a margin that, to me, is very clinically significant. All the milestones can be met with a posterior approach patient too. I want to say the complication profile, overall complication profile, is probably about the same. And I would say the things like wound issues are probably more with anterior approach hips than with posterior approach hips. So you kind of figure out what issue you want to deal with. I think the dislocation question, which is probably why anterior approach leapt over posterior approach in terms of popularity, is not so much an issue anymore with the modern posterior approach. And you can do a posterior approach with the different variations without taking down the rotators. And you can take down all the rotators with an anterior approach. So an anterior approach can be more invasive than some types of posterior approach hips. I typically tell patients that, do you want this for 6 weeks? Because, if you're looking for this for the benefit you're going to get in 6 weeks, then anterior approach no brainer. Or are you trying to do this forever? Like, if you're trying to have a hip replacement that you think is going to last forever, then let the surgeon decide what approach is best for you in their hands based on experience, x-rays, deformities, things of that nature. Any other questions from the audience?
Dr. Kimbo, I see Nena Comas, who's a physical therapist that has also participated in some of our trips abroad. She is on the call. If she's in a position where she can speak, this attempt to get patients out on the same day is obviously multidisciplinary and involves techniques and buy-in and participation from nurses as well as therapists. So it would be good to get that perspective from Nena if she's in a position to respond. Okay, I take it she isn't.
Yeah.
But I think it's a big part of it for us. Head DD invest in resources to make it more possible. And that's exactly what it was for us. And this goes even beyond nurses and therapists. We do have coordinators. And so the coordinators, after we see the patients in the office, will contact the patient, assess their home situations, including the environment, amount of stairs just to get into the house, amount of stairs within the house, whether the patients can function on one floor or would have to keep going up and down stairs, all within the house, distance from the house to outpatient physical therapy, and so on and so forth. We also get them their prescriptions ahead of time. get other assistive devices, their walker, cane, elevated toilet seat. All those things are procured ahead of time. So it's truly a multidisciplinary team that makes this successful, and it begins with people involved in patient care even before the patient is scheduled. And this also touches on the idea of whether there's a cutoff, 75 or above, or whatever age limit. Part of that assessment is based on what is tailored to each patient to see what kind of support they have and what their home environment is and what barriers, medical or social, could affect their ability to go home safely so soon after major surgery.
Dr. Mee, we'll have you just finish up this discussion section with sort of advising us or telling those of us still looking into jumping into same-day discharge, those of us not doing 80 to 90% of our patients as same-day discharge, how to create a program since you were there from the ground up with your program.
Yeah, I think that, Dr. Shah and the discussion has highlighted some really great points that are all great take-home points. I would, tell anyone who's looking at this, for us in our program, when I first got to my hospital, we're still keeping patients for, 2 to 3 days. So we essentially started a same-day program in the hospital. So, what we would do is that we would not order any IV medications. We would, use, more multimodal approach. We wouldn't do any post-operative labs. And, we would get them up the same day. We still keep them in the hospital post-op day 1, sometimes post-op day 2. But once we started seeing they were doing well, with essentially receiving everything that they would be receiving at home, then it was just about getting the patients comfortable with those conversations. And so, for anybody thinking about it, starting to limit all the interventions you're doing in the hospital that you think you need to do just because they're there and you can monitor them. And then once you minimize that, you save costs, and then you realize that clinically you can send patients home. And then investing in that preoperative conversation, like Dr. Onyike said, it's going to be key. You want all those things in place so that, your patients are comfortable. And, Dr. Shah's title for his talk, is it all in our heads? I think it's completely apt, because again, it's about setting the stage, framing the conversation, letting patients know this can be done safely, and making sure they feel comfortable with the resources that you have available to them, both preoperatively and postoperatively. I believe that all the clinical things we're doing in terms of regional anesthesia, periarticular blocks, it's kind of the standard of care for, all high volume arthroplasty surgeons, or low volume, regardless if a patients are staying in the hospital or not. So, not a lot of big tweaks need to be done with that, as long as everybody's approaching those kind of modern standard of care when it comes to total joint replacements. And then, finally, just meeting patients where they are, understanding what their goals are, what their expectations are, and making sure it's truly a conversation and a partnership, and people will have success. I think that as we think about this, there's definitely a cultural part of it, especially in the Nigerian setting, and in terms of patients having expectation that if they're not in the hospital, that they're not receiving everything they're supposed to receive. But again, with the resources in our hospitals in Nigeria, and the success of maybe small boutique hospitals like CAS and things like that, those are perfect settings to be able to do outpatient treatment centers where we don't have the capacity to admit a ton of patients. But if you want to start doing high volume, and you have therapy on location and things like that, I think the same-day discharge in the Nigerian setting is definitely very doable. We just, again, have to meet patients where they are and get them to understand that this is something that can be safe to be done.
Okay. Well, on that note, thank you, Dr. Mee, Dr. Onyike, others that contributed to the discussion, Dr. Kenneth Francis, Dr. Biora, Dr. Stevens. We look forward to having you guys again in a couple of months when we have the next lecture, which should be more dealing with approaches as it regards hip replacements and early discharge. I'll turn things over now to Dr. Onyike to wrap up.
Okay, well, thanks everybody for joining us today. I hope you found the topic to be one of interest, to be one that's relevant and can contribute to advancing our own individual practices, both here in the US and in Nigeria. I believe it was up to date, and it was very fascinating and very relevant. It's part of what we hope to continue to do to take established and also cutting edge topics, put them on the table and have opportunity for us to learn collegially. It's part of the mission of Operation Stand Walk Run. So thanks for participating today, and I hope you continue to stay tuned and join us subsequently. Upcoming for this organization, for those who will be at the AAOS, we are going to have a happy hour reception in partnership with Howard University Orthopedics. That's going to be on Wednesday, March the 8th, I believe, in the evening. So look forward to an announcement on that. As usual, we would have excellent Nigerian cuisine. It will be an opportunity for us to continue to network with each other, meet some of the sponsors and volunteers of our foundation, and hear about upcoming events, including a 2023 anticipated surgical trip to Nigeria. Speaking of that, we've for now targeted November as the date for the next surgical trip. There are some moving parts that we are monitoring, including the elections in Nigeria. And we would hope to frame that up in sufficient time to allow those who want to be part of it to plan accordingly and be there. In between that, we would have our 2023 bike tour. It's been a popular event. Stay tuned for an announcement of that date. So continue to support the foundation. We welcome your participation in our events and your support. And thank you for your time today. Hope you have a good rest of the day and a good weekend. Thank you.